Hey everyone, welcome to this explainer. I am absolutely thrilled you're here. Today, we're basically stepping into the role of clinical detectives. We're going to unpack some of the most dense, high-yield, and frankly fascinating pathologies in endocrinology: thyrotoxicosis, thyroiditis, and the incredibly tricky effects of amiodarone. Now, whether you're prepping for a brutal exam or gearing up for a tough rotation on the wards, you'll see that these are the conditions that often look totally identical on the surface, but they require completely different management strategies. So we're going to solve this medical detective story together and crystallize these complex pathways into concepts you just won't forget.
Okay, let's dive into this. Our roadmap today covers 1. Graves' disease fundamentals. 2. Thyroid eye disease. 3. Treatment and thyroid storm. 4. Thyroiditis classifications. 5. Sick euthyroid syndrome. And 6. Amiodarone effects.
All right, Section 1, Graves' disease fundamentals.
So let's start with our primary suspect when a patient presents with an overactive thyroid. Graves' disease is incredibly dominant here, accounting for anywhere from 60 to 80% of all thyrotoxicosis cases. Honestly, if you see a thyrotoxic patient, the odds are overwhelmingly that it's Graves'. Statistically, it has a prevalence of up to 2% in women, which makes it about 10 times more frequent in women than in men. And your classic patient demographic? That's going to be between the ages of 20 and 50, so definitely keep that specific clinical profile in mind.
Now, you might be wondering what causes it. Graves' definitely has a strong genetic component. There's actually a 20 to 30% concordance in monozygotic twins, but it also kind of needs an environmental trigger to set it off. And this brings us to a fantastic mnemonic, SHIPS. This stands for stress, high iodine, immunomodulator drugs, postpartum, and smoking. I really want to sound a major PYQ alert, a past year question alert, for two of these in particular. First, the postpartum period carries a massive threefold increase in the occurrence of Graves' disease. And smoking? It's not just a moderate risk for the disease itself, it is a major risk factor for developing severe ophthalmopathy.
Moving on to Section 2, Thyroid eye disease.
Speaking of the eyes, let's look closer at thyroid eye disease, or TED. Interestingly, this can actually occur without hyperthyroidism in about 10% of cases, which is known as euthyroid ophthalmopathy. Let's see how this builds. Step by step, the pathogenesis of TED is a truly fascinating cascade. It begins when activated T cells infiltrate the extraocular muscles. These cells then release inflammatory cytokines, like interferon gamma and TNF, which essentially activate local fibroblasts. These hyperactive fibroblasts then ramp up the synthesis of glycosaminoglycans, or GAGs, and GAGs act like microscopic sponges, trapping massive amounts of water. This leads to dramatic muscle swelling and, alongside increased retroorbital fat, it pushes the eye forward, causing proptosis. The absolutely crucial thing to remember here is that late in the disease, this swelling can turn into irreversible fibrosis.
To clinically grade this, we use the NO-SPECS scoring system. It ranges from 0, where there are no signs, all the way up to 6. Grades 1 and 2 cover lid lag and soft tissue swelling. Grade 3 is where we see true proptosis. That's greater than 22 millimeters. Grade 4 involves the extraocular muscles, usually causing diplopia or double vision when looking up and laterally. Grade 5 is corneal involvement, but Grade 6 is your high-yield absolute red flag emergency, sight loss due to optic nerve compression. This is a medical emergency that requires immediate IV methylprednisolone and potentially surgical orbital decompression to literally carve out space in the bone just to save the patient's vision.
All right, Section 3, Treatment and Thyroid Storm.
So we know how it happens, right? Now, let's transition to the counterattack. How do we pharmacologically tame this overactive gland? And what exactly do we do when it spirals into a life-threatening crisis? Let's compare our two main antithyroid drugs, or thionides, methimazole and propylthiouracil, or PTU for short. Both work by blocking the oxidation and organification of iodide. Now, methimazole is generally your preferred, once-daily champion. But here is the rule of exceptions you absolutely must memorize. PTU is the drug of choice in exactly two specific scenarios: during the first trimester of pregnancy and during a thyroid storm. Why? Well, methimazole is highly teratogenic early in pregnancy, causing defects like aplasia cutis. PTU avoids this and has an added superpower. It actually inhibits the peripheral conversion of T4 to the much more active T3, giving you a vital extra edge when dealing with severe thyrotoxicosis.
But these drugs are not benign. The major side effects include hepatitis, which is more common with PTU, and cholestasis with methimazole. But the one you must engrave in your mind is agranulocytosis.
It occurs in less than 1% of patients, but it is a critical warning. It's idiosyncratic and abrupt. That means going routine prospective blood count monitoring is completely useless. You literally cannot catch it early with routine labs. You must educate your patients that if they develop a sudden sore throat, fever, or mouth ulcers, they must stop the drug immediately and go get an urgent blood count.
Now, what if the worst happens and the patient tips into a thyroid storm? This is a rare but frankly terrifying complication with a mortality rate of up to 17%. You must execute a strict prioritized sequence here. Step 1. Give PTU to block synthesis and T4 to T3 conversion. Step 2. Give SSKI, or saturated solution of potassium iodide, to block hormone release via the Wilf-Chaikoff effect. But note this vital caveat. You must wait exactly 1 hour after giving PTU before giving SSKI. If you give the iodine too early, the thyroid will just use it as fuel to synthesize even more hormone, which is the last thing you want. Step 3. Propranolol to block sympathetic activity. And Step 4. Hydrocortisone steroids.
To make this complex and life-saving protocol unforgettable for exam day, I want you to use this cognitive anchor mnemonic, BBBBGCS. Block synthesis with PTU. Block release with SSKI 1 hour later. Beta blocker for the symptoms. Big steroids, glucocorticoids. Cholesterol to sequester circulating hormones in the gut. And finally, supportive care. So cooling, oxygen, and treating the underlying precipitant, which is usually going to be an infection or surgery.
Okay, Section 4, Thyroiditis Classifications.
Now let's introduce the imposters. These are conditions characterized by inflammation and stored hormone release, rather than true overproduction. And this brilliantly illustrates how we categorize these imposters, by pain. In the subacute or de Quervain's thyroiditis row, it is exquisitely painful, often with pain radiating to the jaw or ear, typically right after a viral infection. Because it's destructive inflammation, the ESR is sky high, but thyroid antibodies are negative. Now contrast that with silent or postpartum thyroiditis. That one is painless. The ESR is totally normal, but the TPO antibodies are highly positive. Both of these will actually show a low radioactive iodine uptake simply because the gland is damaged and shut down, not hyperactive like we saw in Graves.
For subacute thyroiditis, you can anchor the treatment with the BANG mnemonic. Big aspirin, anti-inflammatories, no antithyroid drugs, and glucocorticoids if severe. I really want to highlight that N, no antithyroid drugs. Why? Because the thyroid isn't making excess hormone. The factory isn't in overdrive. Basically, the factory's on fire and the existing inventory is just leaking out. Antithyroid drugs like methimazole will do absolutely nothing here.
Moving right along, Section 5, Sick Euthyroid Syndrome.
Shifting gears to non-thyroidal illness, or sick euthyroid syndrome, we see that acute, severe systemic stress, like say being in the ICU, fundamentally alters peripheral thyroid hormone metabolism. The adaptive mechanisms at play reveal that the most common pattern is low T3 syndrome. When the body is critically ill, cytokines like IL-6 spike. This directly impairs the deiodinase enzymes that normally convert T4 to the active T3, so T3 drops. Simultaneously, the alternative pathway ramps up, converting T4 into inactive reverse T3. And because the clearance of reverse T3 is also decreased, it spikes. The body is essentially hitting the metabolic brakes to limit catabolism during a severe illness.
Listen, here is a massive clinical pearl. Do not routinely test thyroid function in acutely ill patients unless you strongly suspect underlying thyroid disease. It will only confuse you. If you do test, a completely suppressed TSH under 0.01 indicates true primary thyroid disease. However, as the patient recovers, their TSH might transiently rebound, sometimes spiking above 20. Never, ever automatically treat an acutely ill recovering patient with thyroid hormone based on this misleading lab rebound. You've got to just let the axis reset.
So, we've covered autoimmunity, inflammation, and critical illness. But what do you think happens to the thyroid when you introduce an incredibly common antiarrhythmic drug that is a staggering 39% iodine by weight?
Which brings us to our final stop, Section 6, amiodarone and the thyroid.
Let's unpack this amiodarone paradox. A standard daily dose of amiodarone delivers a 40-fold increase over the normal daily iodine requirement. 40 times! It fundamentally disrupts thyroid physiology. And here's the kicker. Greater than 6 months. That number represents exactly how long amiodarone's high iodine load persists in the body's adipose tissue even after a patient stops taking the medication. You can't just stop the drug and expect the thyroid issues to magically resolve tomorrow.
So the crucial point here is distinguishing between the two ways amiodarone causes thyrotoxicosis. AIT, or amiodarone-induced thyrotoxicosis, basically comes in two flavors. Type 1 is a classic Jode-Bazadel phenomenon. You're dumping massive amounts of iodine onto a pre-existing abnormal thyroid, like an underlying Graves or nodular goiter. Because it's overactive, a Doppler ultrasound shows increased vascular flow. You treat this by shutting down synthesis with antithyroid drugs and perchlorate. Type 2, on the other hand, is a direct, destructive thyroiditis. The drug itself is toxic to the follicles, and because it's destructive, Doppler flow is decreased. You treat this inflammatory destruction with glucocorticoids.
To cement this into your brain forever, just remember this simple rule. 1 is jumpy, 2 is destructive. Type 1 is jumpy. It's overactive Jod-based out with increased vascularity. Type 2 is destructive. It's a toxic thyroiditis with decreased vascularity requiring steroids. We've explored the triggers, the cascades, the treatments, and the imposters of thyrotoxicosis today, but I want to leave you with a real-world clinical dilemma that underscores just how incredible and complex the endocrine system really is. Given that stopping amiodarone provides absolutely no immediate benefit to the thyroid due to its massive half-life and adipose storage, how do you, as the clinician, balance managing a potentially fatal cardiac arrhythmia against an unfolding, destructive thyroid storm? It's a total tightrope walk that requires absolutely everything we've learned today. Thanks so much for joining me on this explainer, and remember, keep thinking like a detective.